Welcome, everyone. Again, I'm Marcia Stedman, President of Healthcare for All Washington, and pleased to welcome you to our 2021 annual program and membership meeting. I'd like to begin, though, with a land acknowledgement, thanking the Coast Salish people for their stewardship of the land on which I live, and acknowledging that wherever we live on this planet, we are but the current occupants of land that Indigenous peoples first occupied and still occupy today. It is our shared duty to take care of these lands so that they may be preserved for many more generations to come. Thank you. Well, 2021 was truly a remarkable year for Healthcare for All Washington. Of course, we had the big win. The Permanent Universal Healthcare Commission is now codified into law. The members have been selected, and they are going to begin their meetings soon, we hope. It's about time. Other important laws that will provide data the Universal Healthcare Commission needs to design our universal healthcare system were also assigned into law. We'll have more details on that a bit later in the program. We also, as an organization, we initiated our second Wednesday speaker series with a focus on health equity issues, together with other communications enhancements like recording the proceedings and posting them on our YouTube channel. We invite you to check that out. You can get there via our website and click on the events tab on the top, and then the second Wednesday speaker series archive will pop up for you. So it's thanks to Healthcare for All Washington's strong leadership and generous support from our volunteers and donors that made these gains possible. Thank you from the bottom of our hearts. So it's now my pleasure to talk a little bit about Steve Kemble. In a country where healthcare is driven by dollars, we are fortunate indeed to have Dr. Stephen Kemble with us today to explain the ins and outs of healthcare financing and insurance in our profit-driven healthcare industry. As you know, the actuarial studies done for the Universal Healthcare Work Group last year showed the publicly funded universal healthcare would save the state billions of dollars every year in healthcare spending. But is it feasible? Everybody wants to know. Well, by addressing the good, the bad, and the ugly of the healthcare financing schemes out there, Steve will give you the background you need to understand and talk about the most financially feasible way to achieve those savings while giving everyone the healthcare they need. Dr. Kemble is a practicing psychiatrist and past president of both the Hawaii Psychiatric Medical Association and the Hawaii Medical Association. A healthcare financing expert, he has a long-standing interest in healthcare reform. He has been appointed to the Hawaii Health Authority, which is charged with overall health planning for the state of Hawaii and with designing a universal healthcare system covering everyone in the state. His experience will inform our own Universal Healthcare Commission as they begin designing Washington's system. Now, at Steve's request, we have posted a link to the PDF of his slides in chat to aid you in your understanding of his narrative. And should his presentation stimulate a question, please enter it at the Q&A button on your screen. I first heard Dr. Kemble speak at one of the very first Healthcare for All Washington annual meetings I ever attended. That was back in 2011. It's been a long time. So I have appreciated over the time his expertise and learned so much from him over these past 10 years. So it gives me great pleasure to welcome Steve once again to this virtual space. Welcome.
So the title of my talk is Insurance Industry Trojan Horses, What's Wrong with HMOs, ACOs, Direct Contracting Entities, Medicare Advantage, and Medicaid Managed Care. There have been recent news articles about DOJ responding to whistleblower complaints of massive fraud in Medicare Advantage plans, which involves upcoding of plans. They interview patients, they go through doctors' offices' records, looking for more diagnoses that hadn't been included in the claim, and looking to see if a patient can be re-diagnosed with something a little more severe sounding than what they were originally diagnosed with. And the result of this is that Medicare Advantage payments, about 10% of what they're being paid is probably improper. And this is about $30 billion a year that's going astray. There are similar whistleblower lawsuits pending or have been settled against Medicare Advantage plans run by a whole gamut of major insurance plans. So how do we get to this and what can be done about it? Okay, why privatize? A lot of money flows through public healthcare programs, particularly Medicare and Medicaid, also publicly funded employee health benefits, and private interests, business interests want to tap into it. If they are just processing claims, which is the necessary administrative part, that's only about 2% of the healthcare dollar. But if they can persuade government programs to allow them to take on insurance risk and manage care, they have been able to reap 12 to 40% of the healthcare dollar. So obviously they're pushing the latter. So they need a rationale, so they make stuff up. Government is always inefficient. Private insurance companies can manage healthcare to make it more effective and cost-effective. Fee-for-service incentivizes doctors to deliver excessive volume of largely unnecessary care, and this is the major driver of excessive costs in U.S. healthcare. We, the insurance companies, can rein them in. Care is fragmented under fee-for-service, and private health plans and integrated delivery systems can more effectively coordinate care, restrain unnecessary care, improve access, and reduce cost. Turning healthcare funding over to capitated private entities makes your cost predictable, and competition and market forces will control costs. None of this is actually true. None of it. It's all made up to serve the insurance industry's interest in tapping into the finances of publicly funded programs. Large numbers of politicians and health policy experts have been drinking this hallucinogenic Kool-Aid. Oh, I missed this one. The Affordable Care Act has accelerated privatization by requiring everyone to move away from fee-for-service with its volume incentives and replace it with value-based payment, shifting insurance risk onto providers of care with capitation and bundled payments. Accountable care organizations were created by the Affordable Care Act, or we can have large insurance plans and hospital chains paid with capitation, buy out physician practices and integrate them. So this has been going on since the 90s when we had the first wave of managed care, capitation, and HMOs, but this failed due to the backlash against the incentive with capitation to skimp on care. But then in the 2000s, the same rationale came back with pay for performance or outcomes. So if you hold providers of care accountable for the cost and outcomes of care, then they should provide better care. What this fails to account for is that the bulk of outcomes is not determined by the doctor's effort or the hospital's efforts. It's determined by patient characteristics. So what you're doing is incentivizing cherry picking and lemon dropping. In the 2010s, we've had value-based payment and accountable care organizations, more of the same. And value-based payment has been promoted by the Affordable Care Act and CMS through Medicare and adopted by many commercial and Medicaid plans. The latest is direct contracting entities, which is an attempt to organize the remaining fee-for-service, regular, traditional Medicare patients into capitatable organizations of doctors and hospitals called direct contracting entities, and the patients won't even know they're being put in them. So this is stealth privatization of the rest of Medicare. So all these rely on the same false rationale that excessive healthcare costs is due to unnecessary care caused by fee-for-service. And they all have the same solution, which is shift insurance risk onto doctors and hospitals so that they keep more money by delivering less care. But risk management requires big data. You need very detailed information on patients' diagnoses and how sick they are and what their risks are in order for you to, quote, manage risk. But in practice, managing risk mostly boils down to risk avoidance because there isn't that much that doctors and hospitals can do to make care more cost effective, but there's a lot that they can do to hang on to healthy people and kick out the sick people. And big data cements the role for insurance industry and healthcare, so they love it. Utilization of care under fee-for-service in the US has been low compared to other countries that cover everyone for half what we do, often using fee-for-service. And there is no evidence that excessive utilization in primary care has been caused by fee-for-service when paid with fee-for-service. So this is something that was made up by the insurance industry. There are anecdotal reports of certain hospitals, especially for-profit ones, that push their employed procedural specialists to do unnecessary care. And there probably is some in every country, but we have no more of this than any other country. So this does not explain our high cost. And when you rely on capitation, which means you're paid up front for care for a population of patients over a specified period of time, and you get to keep whatever savings you get if you spend less than that capitated amount, and you lose if you spend more than the capitated amount. So there's opportunity for profit and loss. When you set payment for care up that way, it gives an incentive to skimp on necessary as well as unnecessary care and to avoid sicker, more complex and socially disadvantaged patients. Or in other words, cherry picking and lemming droppings. These are not problems with fee-for-service because there is no risk shifting involved and there is no advantage to avoiding sick people. So overutilization of care is a trivial problem. The OECD data shows that our doctor visits per capita and hospitalizations per capita are among the lowest among industrialized countries with universal healthcare system. And there was one study that actually looked for overuse of healthcare services in the United States and found remarkably little, much less than they expected. So this cannot possibly be the cause of high US healthcare costs. And there's plenty of evidence that the difference is high administrative costs due to administrative complexity, which drives higher prices and high pharma prices. But corporate fraud and abuse by insurance plans, HMOs, Medicare Advantage, and Medicaid managed care, all of which are capitated entities, is widespread and hugely expensive. They all engage in cherry picking and lemon dropping, upcoding, deceptive marketing, denial of necessary care, narrow networks, restricted access to care, slow claims processing, high rate of denials, and meaningless quality metrics that have more to do with what's easy to measure than what matters to a patient. So let's take a deeper look at capitation as a payment system. So insurance is a system for managing financial risks, and it's designed for risks that are infrequent, expensive, and unpredictable. For example, if lightning strikes your house and it burns down, everyone pays homeowners insurance, and when that unfortunate event happens to you, then the money is there to pay for it. And the primary means of risk management is risk pooling, where everyone chips in and then the money is there because it's spread across a large population that doesn't need any help. The insurance business model also includes underwriting, which is a technique for risk avoidance. Basically, this means analyzing risk for the purpose of either charging more for higher risk or refusing to cover higher risk. And that, although it helps mitigate risk for an insurance company, it's counter to the whole purpose of health insurance. The problem with healthcare is that way too much of the risk is predictable. People have pre-existing conditions, there are demographic factors, social determinants of health. All these make risk substantially predictable so that the insurance business model becomes counterproductive and toxic in healthcare. The strongest determinant of financial success is securing a healthier than average risk pool. And underwriting and cherry picking undermine the whole purpose of health insurance. Underwriting has been restricted under the Affordable Care Act, but cherry picking and lemon dropping are still going on. Okay, a risk-bearing entity is any healthcare in healthcare is an organization that has specified enrollees or assignees members. So they're paid per person. That's what capitation is. And they have a contract with either each enrollee or premium paying subscriber, or the payer contracting on behalf of enrollees, such as Medicare and Medicaid, that obligates the organization to pay for all necessary medical services needed for their enrollees over a given period of time. And it includes the opportunity for profit or loss based on the cost of care delivered. HMOs, accountable care organizations, integrated delivery systems, Medicare Advantage, Medicaid managed care, or managed care organizations, and direct contracting entities are all risk-bearing entities. So what's the difference between capitation and budgets? Both involved a fixed payment for covering the cost of care, but capitation is a payment per person and has the opportunity for profit and loss. And it introduces an incentive to cherry pick the healthy and lemon drop the sick, and game diagnoses and documentation to beat risk adjustment formulas. And it requires risk adjustment. Without risk adjustment, if you pay with capitation, you have a very strong incentive to cherry pick and lemon drop. And risk adjustment is supposed to counteract that by paying more for sicker people and less for healthier people. But we'll get into why that doesn't work. Global operating budgets do not convey risk. They're based on the cost of operations, not per person and not opportunity for profit or loss. This is the same as police and fire departments. They're given a budget and it's based on the cost of running their operations. And there is no opportunity to profit or lose. There's no entity that's paying off shareholders or anything like that involved. If something unexpected happens and costs rise unexpectedly, they can ask for supplemental appropriations, or it can be made up in the next year's budget, but they're not expected to take the loss. And at the same time, if there's any money left over at the end of the year, it gets rolled into the next year's operating budget. So there's no retained earnings. Social insurance or single payer is pure risk pooling. Risk is managed by spreading it across the whole population, period. There's no underwriting, no cherry picking, no exclusion of high-risk patients, no gaming documentation to beat risk adjustment formulas. An HMO is an integrated system of physicians and hospitals that can be paid with capitation or premiums, which is the same thing. And enrollees or subscribers are assigned to the plan or sign up for the plan. They know they're enrolled in the plan. And the classic example of a closed panel HMO is Kaiser, where if you're in Kaiser, you have to get all your care there. You can't go outside or they won't pay for it. And there are also many health insurance companies who offer open panel HMOs where there's a network of independent providers that also provide care to non-HMO patients. And Medicare Advantage and Medicaid are HMOs. An ACO is created under the Affordable Care Act. It's an accountable care organization. And it uses, instead of having members, it uses attributed lives where they look at where each individual patient seeks care most often, especially for primary care, and they attribute the patient to that doctor and then can pay that doctor with capitation. The patient may not know they're attributed, but this is a device to enable capitated payment and risk shifting without people being locked into a particular plan like they are with Kaiser. And it requires quality metrics, pay for performance, and risk adjustment to manage risk, which require detailed documentation, data reporting, and that requires high administrative costs. A direct contracting entity, as I said, is a new attempt started in the Trump administration to try to capture the rest of Medicare and privatize it. And like an ACO, it uses attributing or aligning patients according to where they seek care rather than people signing up for a plan. And there are 53 pilot programs sponsored by physician and hospital-led ACOs, insurance companies, and venture capitalists who see the lure of large profits off of taxpayer-funded healthcare. There's a variant of the DCEs, which is the GEO model, which would force all traditional Medicare patients within a geographic region into DCAs. And that's been put on hold, but might be reactivated at any time. Okay, what's the problem with risk adjustment? Healthcare or risk is not evenly distributed or random. It's concentrated in a small percentage of the population with very expensive illnesses. Much of the risk in healthcare is predictable. So this creates a strong incentive to cherry pick and lemon drop. And risk adjustment is supposed to be the solution. You analyze factors predicting cost and pay more for high risk and less for low risk patients and populations. The original Medicare Advantage program used only demographic data for risk adjustment. And they found out after a few years that that was only predicting about 2% of the variability in cost and grossly overpaid for the healthy and underpaid for the sick. So that risk adjuster was not effective as a deterrent to cherry picking and lemon dropping. In 2004, CMS introduced the hierarchical condition categories risk adjuster, which adds diagnoses to the criteria for risk adjustment. This improved the accuracy of the formula from 2% to about 12%. This is still nowhere near enough to prevent cherry picking and lemon dropping, but it did add a great new way for capitated plans, and especially government-funded Medicare Advantage and Medicaid managed care plans, to gain payment, upcoding. So if your risk adjuster is based on diagnosis and you make people look sicker by giving them more severe diagnoses, you can rake in a lot more money. So this is the growth of Medicare Advantage. In 2004, only 5.3% of Medicare patients were in Medicare Advantage plans. And that's when diagnoses were added to the risk adjustment formula. And plans started realizing that they could rake in more money by inflating diagnoses. Then they discovered that Medicare Advantage could be really profitable. And that's why they've been marketing harder. And that's why they've grown to 34% of the Medicare population from 13% in 2004. And risk adjustment cannot be made accurate. If you try to improve the formula by adding more diagnoses or more social determinants, the formula stalls out at about 12 to 15%, and you end up putting more and more effort and more administrative costs into trying to gather more and more detailed data, and you don't get anywhere close to an accurate risk adjustment formula. The implication of this is that this is not a fixable problem. You cannot do without risk adjustment without having a severe incentive to cherry pick and lemon drop, and you cannot prevent that risk with risk adjustment. And if you try to, you introduce new ways for capitated entities to game the system by upcoding diagnosis codes. So now you have both pervasive cherry picking and lemon dropping and gaming of diagnoses by upcoding. So we now have a problem with massive corporate fraud. And upcoding has become an even bigger problem for Medicare Advantage than cherry pick and lemon dropping. The other problem with this is that if you are the patient and you have been given inflated or false diagnoses by your Medicare Advantage plan, and you want to switch out of Medicare Advantage, the rules are you can only do that in the first year, or you are subject to underwriting if you apply for a Medicare supplement plan. And the Medicare supplement plan will get your diagnoses from the managed care, the Medicare Advantage plan, and charge you higher because of those inflated diagnoses. So this follows you after, even if you leave Medicare Advantage, it follows you around. If you apply for life insurance, same thing, it would be held against you. So Medicare Advantage markets to the healthy, is unfriendly to the sick. They discourage sick people by restricting their networks, and they don't take doctors who tend to treat more severe illnesses. They restrict their formularies. They create barriers with prior authorizations. And they upcode flagrantly, so they become very profitable at the expense of CMS and taxpayers. Likewise, Medicaid managed care, which claimed it was going to control cost and improve access to care and improve quality, has been achieving exactly the opposite. It drives doctors out, it reduces access to care, and it raises cost. It's very easy for a Medicare Advantage plan or a Medicaid managed care plan to sell themselves to either CMS or a state, and then the state never looks to see, or the government never looks to see if it turned out the way they said it would, and it's always turned out to be the opposite. There are a couple of examples of going the other direction. Oklahoma was the first. They had part of the state under Medicaid managed care and part under what is called primary care case management, where instead of hiring an insurance company to manage care, they pay the primary care doctors a little extra to manage care themselves. After several years of running these in parallel, they discovered that the primary care doctors were doing a lot better than the insurance companies, and they fired them. Connecticut took note of Oklahoma's experience. They had had full risk Medicaid managed care in place for a dozen years. And in 2012, they finally, after years of trying to extract financial information from the managed care plans and complaining of ghost networks and false advertising, they finally persuaded the governor to eliminate the Medicaid managed care program. They fired the managed care companies in 2012. In the 4 years before that, their costs had risen by 45%. So they followed the primary care case management model. They paid primary care doctors extra to manage care. And they also, the enhanced part, the EPCCM, is they also had community-based programs for frequent flyers in the emergency room, high-risk patients being managed in the community, patients who needed specialized services like the seriously mentally ill or substance abuse services. So they set up all these programs on a non-risk basis. They paid them operating budgets based on the cost of their operations to do what they do and made them available to the whole Medicaid population. So that's the enhanced part. 6 years later, physician acceptance of Medicaid had gone up by about 30%. ER usage was down 25%. Hospital admissions and readmissions were down about 6%. And total per member Medicaid costs, including both care and administration, were 14% lower in 2018 than they had been in 2012. No state implementing managed care has ever seen costs come down. They still go up and down year to year, but the trend is always up. Connecticut actually brought Medicaid costs down. Their administrative cost went from 15 to 40% with the Medicaid managed care organizations, or 12.5% for Connecticut commercial plans, down to 2.8%, including the cost of their administrative services only contractors, which provide necessary administration on a budgeted basis, not a capitated basis, non-risk bearing. So if you go the other direction and get rid of your risk-bearing middleman, you really can bring down costs, and Connecticut proved it. So an optimal single payer bill should include one payer that pays providers of care directly with no subcontracting of funding to risk-bearing middlemen. It should include budgets for institutional providers of care, including hospitals, nursing homes, federally qualified health centers, home health agencies, independent dialysis facilities, and community-based programs for patients with specialized needs. All these should be paid operating budgets. You need a simplified, standardized fee schedule for independent providers of care, independent doctors, and administratively, it's much cheaper to do this with fee-for-service than with any other system. And you can deal with quality improvement directly with quality improvement projects. You can deal with care coordination with those community-based programs for patients with specialized needs. You don't need to pay a financial risk-bearing middleman to do those things. And of course, we could use negotiated price controls for drugs and durable medical equipment. There are many federal and state bills that call themselves single payer, but include provisions for risk-bearing financial intermediaries, HMOs, ACOs, et cetera, because they think these are cost control strategies, even though in practice they're having the opposite effect. And these include Senator Sanders' S1129, California's SB 562, the New York Health Act, the likely results of the new bill being drafted by the Healthy California and Healthy California for All Commission. And there are also recent articles by Don Berwick and Michael Chernow, who are very well-respected health policy experts, recommending including HMOs and ACOs in single-payer legislation. The problem is once you've contracted the money to a financial intermediary, you have created a multi-payer system. It's not single payer anymore. Jayapal's HR 1976, California AB 1400, the Minnesota single payer bill, those are all true single payer bills. The ones that include HMOs, ACOs, et cetera, they are justified by false memes, and they are Trojan horses for the insurance industry to weasel their way back into a supposedly single payer system. Okay, put your questions into the Q&A and we will deal with them in a little bit.
Thank you, Steve. That was really a fast clip with a lot of information, but all of it really essential. So let me be visible to everyone. Hi again. Thank you. So I want to let people know, as Steve just did, to put your questions in the Q&A, and we will have a couple of elements here in the program that will allow our question monitors time to look through those questions and sort them so they can make sense of all the questions that have been asked and make a logical progression out of those questions. So continue to use that Q&A button. So now, first, before we get to the Q&A, we're going to hear from Healthcare for All Washington's Vice President, Ronnie Shure, and he will recap some of those 2021 healthcare legislative victories that I mentioned in the opening segment of this program. So Ronnie, let us know how great we did together with everybody's help.
So I'm sorry that Cindy Laws can't join us today, but I will I will try to give you an overview of the legislative successes. As Marcia mentioned earlier, this has been a very successful several years. The successes from 2021 include the bill that actually started our Universal Healthcare Commission, and we certainly are focusing on membership in that board, in that commission, and meetings that should be starting soon. I think January is the last we told would be the latest beginning, but there will be committees formed by the commission. There will be outreach to the rest of us to include more people than were just the members on the commission. So it's a real exciting beginning for 2022. This has been a victory that started with a budget proviso that created a work group. Many of us were participating in that work group, and a lot more actually added comments to make it a useful process. Even Stephen Kemble gave a national support for this work group that has led to this Universal Healthcare Commission. A second bill on my list was about the affordability of standardized plans on the health benefit exchange. While it's not true public option, it's steps that are moving forward to universal coverage as we include more and more people. We did have a bill, an additional bill about insulin and generic drugs to move the state forward in producing, distributing, and purchasing generic prescription drugs. That will be a long-range plan to replace the current temporary plan that was a victory in the previous years to help control costs. A bill by Senator Kaiser that was started or sponsored by Senator Kaiser created health equity zones to identify some of the inequities and disparities in our system and to help communities create their own approaches and be a part of that process. And a bill on health system transparency, again, moves hospitals to share information. Once we know information about race, ethnicity, gender identity, sexual orientation, languages, and any disability, that way we can start to address it more fully. There are plans to enroll health systems throughout the state of Washington by the beginning of 2023. So it's an exciting start from this year. We also had some bills from last year that have work groups and boards that are being developed to integrate or to expand plans. One of the big victories from previous year, from 2020, was developing a total cost of insulin to limit co-payments to $100 for insured patients who are getting insulin through the state. It's not universal health care, but it's a step forward, and a work group is being developed out of the plan. And we've had several other victories on drug affordability and transparency, prescription drug price transparency. And we've actually had a Zoom meeting earlier this year where people from the Healthcare Authority, from the Department of Health, were able to supply information on where those processes are going. So we're following up on that previous legislation. And it's important to note that legislators are listening to us and are asking us for advice and are asking us to come in and support bills that they are planning. And so it's exciting to be a part of that process and to show the development that's come over years of the previous years that our organization, that Healthcare for All, has made to build community groups, to talk to our legislators. So you are making that difference. And our organization is making a major change and are having a real impact on our legislative process. So it's been an exciting year, and looks like this 2022, although it's a short legislative session, there will be some specific actions there, as well as the impact on our impact on the Universal Healthcare Commission, which we believe will be a true answer. So Marcia, why don't we invite you back in?
Sure.
And you can introduce Chris and Consuelo for the next part.
Yes, we're going to be able to hear how so please, actually, first, please continue putting your questions in the Q&A section of your screen rather than chat, if you would. And what we're going to talk about now, what we're going to listen to Chris and Consuelo talk about are ways that you can participate in our ongoing work to make truly universal publicly funded healthcare a reality in our state and support the commission in their work. Everybody in, nobody out. Take it away. Board member Chris Covert-Bowlds and new member Consuelo Echeverria.
Thanks very much. Hi, I'm Chris Covert-Bowlds. I'm a family doctor in Seattle and very motivated to help get health care for everyone in the state. In the next 10 minutes, we hope to raise $12,000. Good news is we already have a match from our board members for $6,000. So all we need to do is get the other $6,000. Please check the link in the chat to donate. And if you can, monthly donations are much better than one-time donations. If you want to remain anonymous, just check the box at the bottom of our donation page. And our C4 group allows us to lobby most effectively and extensively. But if you need a tax deduction, you can donate to the C3 Education Fund. Go ahead, Consuelo.
Hi, I'm a new member here at Healthcare for All Washington, a new volunteer. And the reason why I started to volunteer was because I spent 20 years living in Istanbul, Turkey, which just has a form of universal health care. And after a couple of years here in the States, my sister was rightfully appalled that I hadn't gotten my health care act together yet. And my mother popped up and said, "What do you mean? Why should she have thought about it? She lived for 20 years in a country where the health care was covered by the government. Why should she think that the US was any different?" And that is why I volunteer with Healthcare for All Washington, because the US shouldn't be any different.
Yes, and as a family doctor, I've seen way too much suffering and death. In fact, twice I ended up writing lack of health insurance as the underlying cause of death on 2 death certificates. I definitely still remember a woman who had very advanced breast cancer. She was very afraid of the cost of it and came in much too late, and we did everything we could, but she died very soon. Another woman with clear heart disease who had no health insurance, and despite having our best program we could have up in Bellingham for specialists to donate their services and various donation programs, she was too afraid, I think, of the cost, and so died shortly thereafter. And I said the lack of health insurance was the underlying cause of death. I was not allowed to keep that as the answer because that's not allowed in the state forms. And just imagine how much we would see if we could actually document that. But so I don't think anyone should have that to make them suffer or die. So.
Absolutely. And Chris's story really highlights the importance of our work to make Washington a leader in universal health care so no one else suffers or dies from lack of health insurance. And here comes our first ask. Please do dig deep. Chris?
Yeah, so please take a look in the chat again for the link to our donation page. And again, if you want to remain anonymous, just check that box. And again, the C4 is our most effective lobbying, unlimited funding. But if you need the tax deduction, just choose the C3, our education fund. Again, we're aiming to raise $6,000, and then our board will match up to $6,000 already pledged. And again, monthly donations are the best if we can. If you can donate at the $5,000 level, that would be fantastic. That would fund an entire year of printing and a year's worth of media campaigns and event announcements to get our message out to people. If $5,000 doesn't work, $2,500 can fund an entire year of printing costs for flyers and pamphlets and other informational documents that we can help persuade our legislators to support healthcare for everyone.
And while everyone is filling out those $5,000 donations, I would just like to share that GoFundMe reports that over 1/3 of all of their donations, for a total of $650 million, was used to cover healthcare costs. With your support, we can have the opportunity to change this profit-driven system and be a leader in the United States.
Yes, and Healthcare for All Washington is the only organization in Washington state whose sole mission is to achieve state-based universal health care. So again, please click on that link in the chat to donate. Again, you can be anonymous, and we're raising money as we speak. At $1,000, you could fund 2 full days of lobbying in Olympia, a banner for our visibility, and all the materials we would need for a strong outreach event. At $500, that would fund a full day of lobbying in Olympia, a smaller banner, and a roll of stamps so we can get our materials out to people by mail.
And while those donations are rolling in, I just want to highlight our work in Olympia. Back in 2019, Healthcare for All Washington was a key player in drafting the bill that created this universal healthcare work group. We lobbied heavily for its passage in the Senate and for the funding in the House budget. And then for the 15 months of its existence, we helped drive public comments on the work group that led to the creation of the Universal Healthcare Commission. Chris, on to you.
Yeah, now that the commission's been formed, we are thrilled that 5 of our suggestions are on the board, including the chair, Vicki Lowe. So we've got our people helping to lead the effort. And we're also keeping our members in the loop on our victories so that when we can advocate if things get stalled. Currently, the health system transparency law requires detailed reporting of hospital revenue and expenses is stalled in the 22 budget. So we need to keep pushing to get that funded in the 22 supplemental budget.
Absolutely. And we are doing a lot of community advocacy to keep these slew of healthcare victories alive. And we really do need your support. to keep that happening. For example, $250 can cover the printing of one issue of Healthcare for All Washington newsletter. $100 can supply the materials for a volunteer training session in your legislative district. And I would just like to say that I'm in the 36th, and we had Marcia and Ronnie and I believe Sherry come and speak, and it was fantastic. I highly recommend that you invite us to speak. Our board president and the new vice president are fantastic speakers and extremely knowledgeable. The Dreamer level is $100, which can buy 100 buttons for our supporters at the legislative hearings to make us more visible. We'll even send you one too.
Yes, and we have a speaker series on Wednesdays. Most recently, Vicki Lowe, who's the chair of this Healthcare Commission. She's for the American Indian Health Commission for Washington. She spoke, and also Catherine Seibel from the National Alliance on Mental Illness. She highlighted the important legislation like the statewide Office of Behavioral Health Consumer Advocacy, which is empowering advocates for those in psych units as well as hospital accountability.
Fantastic. So we'd like to thank some of the people that have volunteered for donations. Maureen, thank you so much for your generous donation of 100. Gary as well, thank you so much. And Al, thank you very much for your $250 donation. We are moving towards that $6,000 goal. Now I've lost my place. Here we go. Healthcare, sorry about that. Healthcare for All is forming a health equity team, which is very exciting. With your support, we'll be able to gain insight into the health status and needs of the homeless community, as well as the diverse communities who help make Washington their home. If you are interested in joining the health equity team, please contact us via the Get Involved tab on our website. And I'm putting the link in the chat as well, the volunteer link in the chat as well.
Excellent. Yeah, I'll also remember there's a bunch of more donations that have been rolling in. Thanks very much for those. You see Maureen for $100, Gary for 100, Al for $250, Dana for 100, Reed for 200, John for 100, Andrea for 25. That's a huge help. Thanks very much. That's really going to help a patient of mine, similar situation. He had prostate cancer that was very well controlled with a simple monthly injection, but due to the cost, which was over $1,000 per month, as I recall, he ended up having to decide to basically get castrated for what was a completely controllable cancer with a simple monthly injection, just due to our high medication costs. And I don't think any American should ever have to face such an awful choice. So that's why I'm motivated to help make sure we get decent, good, affordable health coverage for everyone.
Absolutely. We really do need to change, as Dr. Kemble's speech presentation highlighted, this profit-driven system. It's absolutely inhumane. Please do continue to give. I believe that we're almost ready to answer the questions. And while we're answering the questions for Dr. Kemble, remember, no matter how much you're able to give, any amount gets us closer to our goal. Thank you so much. And Marcia, I believe it's on to you.
Thank you, Consuelo. That's great. And Chris, too. Good to hear from you both. And thank you to the donors so far this afternoon who have donated generously to our ongoing work. Very much appreciated. So at this time, we are going to, let's see. We're going to have the Q&A begin. So that would mean we'll hear from Gary and Sherry. Gary Goldbaum and Sherry Weinberg, and they will be on screen and sharing your questions with Dr. Kemble, who will be on screen too.
So let me first check. Can you hear me?
Yes.
Great. Dr. Kemble, can you hear me?
Yes.
Terrific. Well, we have a number of questions for you. And so in the short time that we have, I'll try and get through as many as we can. I'm just going to give you the heads up that we do have quite a number of them. So let me start with the first question. Can fee-for-service models focus on preventive care as much as curative care?
There's no reason why not. All you need to do is have a procedure code for preventive care that has a fee attached to it, and you can include it in a fee-for-service system. There's nothing about fee-for-service that would interfere with preventive care or discourage preventive care.
Thank you. The next question. Nora asks, are doctors now paid solely by diagnosis? Don't they have to supply supporting data or on treatments? For example, upcoding from obesity to morbid obesity doesn't require BMI data or weight loss plan, is that right? How can they upcode and not incur more expense without additional treatment or with additional treatment?
You have to distinguish between the way the health plan, the risk-bearing entity is paid and how the doctor is paid. So if it's a Medicare Advantage plan, they are paid by the person, and then it's adjusted based on the diagnoses that the patient has been given by the doctor. The doctor may still be paid with fee-for-service. So they need to submit a diagnosis to support a claim, but they don't need to. It doesn't matter which diagnosis they choose, just a diagnosis is all they need. So the health plan comes to the doctor's office and says, you put in a diagnosis of obesity. Do you think this patient might qualify for morbid obesity? And the plan gets more money for that, not the doctor. So if you capitate the doctor, which is being done in many places, then the doctor is the one with the incentive to upcode.
So at the moment, you would say that the doctors are not getting an incentive to upcode. It's really at the plan level.
Generally, yes.
Okay. Here's a more complicated question from David Loud. So have these issues that you've been raising, have they also been raised by advocates working for universal health plans in New York and California? And with what impact so far? Because those states seem to be very interested also in healthcare reform.
They have been raised in both New York and California. The problem is that there are some of the people on the Healthy California Commission who are really invested in the Kaiser system and in HMOs and ACOs. And even though these concerns have been raised, they've basically got their fingers in their ears. There is a process going on now to try to develop a new bill for California. And California already has a bill available, which is AB 1400. That's a true single payer bill, but it excludes HMOs and ACOs. The way that bill would deal with Kaiser is that you could take a hospital and the physician group and pay them together a global operating budget. And that would be fine in a single payer system. But that means that there are no members anymore because they're not being paid per capita. And it means Kaiser becomes an open system and there's no opportunity to profit or lose and no funding for empire building and chain development and things like that. So basically it preserves the hospital and doctor as an integrated system and eliminates the insurance functions, the chain, the corporate C-suite, all that stuff would go away, but the doctors and hospitals will be kept whole. And that's fine with a single payer system.
There's a second part to this question. Is HH Secretary Becerra doing anything to curtail the direct contracting entity scheme for 2022? What exactly has been put on hold for 2023? Do we have reason to think that the administration understands and is opposed to this and other forms of privatization of Medicare?
There are several, I think there are 4 US Congress people who sent a letter to Becerra saying they're very concerned about direct contracting entities because so many of them are funded by venture capital or insurance companies, and this is a serious problem. But there has been no response that I'm aware of from Becerra saying, okay, we hear you, this is what we're going to do. But the issue has been raised. The geo problem, which would take a geographic area, I think there are about 12 of them, and require everyone in that area to be assigned to an ACO or an HMO as a direct contracting entity. So it would totally privatize Medicare. That's been put on hold, but it has not been killed. It has not been said we're not going forward. There are still people in leadership positions at CMS who totally believe in ACOs and risk shifting as the solution, so-called, to our healthcare cost problems. And until those people are either gone or dissuaded of their false beliefs, then we're at constant risk from this.
Okay, here's a more technical question. Could you explain the difference in operating and capital budgets in global budgets and what we have now in our private system?
Okay, what we have now in our private system, which I'll cover first, is that the hospital is paid either fee for service, or if they've integrated with doctors as an integrated delivery system, they're paid with capitation. So, excuse me. Wait, repeat the question again.
Explain the difference in operating and capital budgets in global budgets and what we have now in our private system.
If they're paid with fee for service or capitation, they're not, that's not the same as a operating or global budget, either operating or capital. But out of that money, they try to fund capital expenditures. So if they're capitated a certain amount, they spend so much in healthcare and sets a certain amount aside to build a new hospital wing or new facilities or whatever. And it's a competitive environment, so they're trying to beat out other hospitals and having certain facilities, and you end up with duplications in the community and a lot of waste in doing it that way. With global budgeting, you would pay the hospital. This is the way it's set up in HR 1976, AB 1400 in California, the Minnesota bill. You know, the good single payer bills all do it this way. A global operating budget covers operating expenses, and it's intended to cover the cost of operations. Capital expenditures are funded from a separate fund, which is allocated according to community need. So there's a commission that would look at a community and say, do we need another MRI facility there? Do we need another hospital there? And of course, you've got hospitals clustered in the suburbs and none or one available in the inner city poverty areas or in rural areas. So obviously that commission would say, we need a hospital in those areas. We don't need another suburban hospital. And they would give the capital expenditures money to whatever entity was going to build the hospital in the right place with an obligation they had to do that. And they would not, there would be no way the hospital with a global operating budget would be able to fund capital expenditures except by applying for a grant from the separate fund, showing the need and getting paid to do it. They wouldn't be able to mix the two together.
Okay, thank you. So, a question from Dana. It is my understanding that Congress has no authority over the DCE privatization schemes. Who should we be lobbying to address this draconian policy?
Yes, the Affordable Care Act includes the CMMI, the Center for Medicare and Medicaid Innovation, which is given the authority to try new ways of paying for care, which has primarily all been pushing for shifting insurance risk onto providers of care as much as possible. So that's been set up by the Affordable Care Act, and there's no further accountability. The CMMI can do whatever they want with no input from Congress. So we would need to change the law that created the CMMI and strip it out of the Affordable Care Act. So that's what we have to do.
Okay. Libby asks, this is an interesting personal question. As it turns out, my care is being provided by two separate medical care facilities that are part of DCEs. Is there anything I can do to opt out, or do I need to switch my care? What can we do to protest this involuntary inclusion in these groups? And I would just ask, is it necessary to try and opt out, or what alternatives would a person have?
All right, that's a very good question, interesting question, because with the DCE, the patient is not locked into the DCE. They're not a member. They're attributed to particular doctors. And so the DCE is formed because the doctor has signed a contract to be part of the DCE. And it's usually through an ACO that they were already working with, or or a Medicare Advantage plan that they were already participating in. So the doctor has signed up for a plan, and if Medicare determines that you are seeing a doctor who has signed up with the DCE, then you're in the DCE without knowing about it. But if you want to get part of your care with another doctor, like a specialist, you can. There's nothing about DCEs that locks the patient in, but it does enable Medicare to pay the doctor with capitation or through a capitated scheme. The organization above the doctor may be capitated, or they may capitate the doctors the way some accountable care organizations do. But the patient is still free to seek care anywhere and is not locked in. But the payment system then rewards the system in all the ways that insurance companies are rewarded: denying care, skimping on care, cherry picking, lemon dropping, upcoding. All those things now are incentives for the doctor, and the patient doesn't even know about it. And there's nothing to opt out of because you're not locked in. You'd have to change your doctor, and you'd have to find out if the doctor's in a DCE.
How actually would one find that out?
Yeah, you could ask the doctor. That's the only way you'd know.
Will doctors know that they're in a DCE if they are part of an ACO?
I think for a DCE, the doctors do have to know that they're part of it. But once, it's often an organization they're already involved with, they've joined an ACO, or they're participating with Medicare Advantage or a Medicaid managed care plan. And that plan then becomes a DCE and brings all the doctors along with it. I don't know that the doctors have to know, but I would hope they're at least told that there's a new line of business that their controlling entity is operating in.
Here's a question from Nora. How do HMOs accomplish lemon dropping? Can they actually kick people off that they don't want? Or can they only frustrate people to the point where they leave voluntarily?
It's primarily the latter. The way they cherry pick is by marketing to healthy. You know, Kaiser's ads are all about Thrive, and they have gym memberships, and they're trying to attract seniors who are largely healthy. So that's how they cherry pick. And they promise all these extra benefits, which they pay for with the money their ill-gotten gains from upcoding. They use those to pay for extra benefits that regular Medicare doesn't have. Regular Medicare has quite a bit of holes in it, so they take advantage of that by filling in some of those holes and making their plan sound much better. But the lemon dropping is at the other end, where they restrict formularies, they restrict their network of doctors, and they make it frustrating to get care if you have a serious illness.
So, question from Sherry. I would love to be a volunteer lobbyist. I'm a retired physician due to disability who has major difficulty finding a physician to see me due to cherry picking. I'm also able to speak and give presentations. I'm financially strapped due to being diabetic. How can I volunteer? Perhaps that's going to be a question really to come back to Marcia and the HCFA leadership. Let me move this one on to a question. CMS seems to be pushing Medicare Advantage plans in spite of concerns about upcoding without providing necessary access or services or treatment. Is there any movement to address the issue of upcoding increasing Medicare expenses?
The Medicare Payment and Advisory Commission, MedPAC, has been concerned about overpayment of Medicare Advantage plans all along. The problem is that the legislators are heavily influenced by lobbyists from the insurance industry who are constantly being told fee-for-service is the problem, Medicare Advantage delivers better care for less money, and it's the way to go, and you should be supporting us. What happens is the plans, if the plan cherry picks and lemon drops and upgoes, in effect, what they do is they secure a healthier than average risk pool, make them look sicker than they are. They don't need to spend that much money on them because they're really not that sick. So they can say we're spending less per person than regular Medicare, and our quality metrics are better because they've cherry picked the patient population. So they can make themselves look really good, but it's a shell game. They're capturing the healthy, exploiting them, pushing the sick onto someone else. The whole system is not being made more cost effective. They're just separating out an area where they can make themselves look good at the expense of everyone else.
That leads to this question. What incremental steps could move us towards a direct pay fee-for-service model. What about the public options that are being proposed in Washington State and elsewhere?
The problem with public options is that the private plans engage in cherry picking and lemon dropping at the expense of the public option. So the public option always gets stuck with the sickest risk pool. Then it looks like it's more expensive. And then they say, see, it doesn't work, or they require more funding because it's more expensive and the legislator doesn't want to pay for it. So you got the private option versus the public option pitted against each other. That's the big problem with the public option. I think the thing at the state level that would help the most is to start with Medicaid and state and county employee and retiree health benefits and kick the insurance companies out of those programs, take back insurance risk, pay for care directly, use the Connecticut enhanced primary care case management model to improve primary care pay and set up community-based programs for special needs, save money, show that it can work, and that it works because we've kicked out the middlemen. A state has control of Medicaid and can do that.
There is widespread concern about, in the medical community, about the role that government takes in managing medical care. And of course, some of us are concerned about some of the actions governments have taken elsewhere, like in Texas with respect to abortions. So how does one overcome the resistance to change in the medical community, the reluctance to enable government to have control? And are there examples in other countries of successful models using this direct fee-for-service approach where the physician, the provider community feels this is a fair shake for us and for the patient?
Well, Canada is a terrific example right next door of using direct fee-for-service payment of doctors with the state taking risk and no fiscal intermediaries. And pretty much any other advanced country is doing a lot better than we are at this. So it's not hard to find international comparisons. Excuse me. What was the first part of your question?
Well, it was about the incremental steps that we might take.
Yeah, that's deprivatize Medicaid is the first one, and public employee benefits. That's the first one. And the other thing I was going to say is if you do that and show that it works, then doctors come on board. You ask about resistance from doctors. So in Connecticut, whether the doctors were in favor of it or not, once they got the insurance company, the managed care companies out, the doctors all were much happier. Acceptance of Medicaid went up markedly. They raised primary care pay substantially as part of the primary care case management, but they didn't raise specialist pay at all. They left it at 57% of Medicare rates. Yet specialists increased participation in Medicaid almost as much as primary care because now they were dealing with physician colleagues. And there was no managed care company getting in the way in between, and they wanted to help out their colleagues and they were willing to take the patients again. So physician participation, physician satisfaction both went up markedly after they did this. So you kind of have to do it and then show that it works before people will believe it.
So I'll take the opportunity to ask you a final question. You're in Hawaii, and I understand that Hawaii is also experimenting with trying to improve healthcare. What's happening there, and are you satisfied with that? What steps do you think need to happen in Hawaii? Just let us all know what's going on there.
Okay, Hawaii has been a very disappointing situation just to begin with. We got a law to create the Hawaii Health Authority that's supposed to be responsible for overall health policy and guiding Hawaii to a universal system covering everyone. That passed in 2009. Our then Republican governor refused to implement it. In 2011, we elected Neil Abercrombie governor, who had been our congressman before that and was a supporter of HR 676. So we were very hopeful that now we could move forward. He did indeed appoint the Hawaii Health Authority. I was one of the original members. And we started planning for how to get from where we were to a universal healthcare system. The problem was that at the same time, the Affordable Care Act passed. And Abercrombie had been a personal friend of Obama's parents when Obama was born. And he wanted to be the flagship for Obamacare. And he wanted Hawaii to focus on implementing, the insurance exchange and all the elements of Obamacare, which was going in a very different direction from what we were recommending, which is deprivatize Medicaid and employee benefits, standardize them, make them administratively simple, and then expand it by regulating commercial insurance. That was our game plan. So this is the opposite of what the Affordable Care Act was calling for. And Abercrombie had no money in his budget for planning for how to implement the Affordable Care Act. The Hawaii Health Authority had been allocated $100,000 by the legislature for administrative support. So what he did is he convened a new plan, the Health Transformation Initiative. He went to the insurance companies and the big hospitals for funding. He took our money and threw us under the bus, and everything from there on was controlled by insurance companies. And we ended up with, we used to have the most cost-effective system in the whole country. We had an employer mandate since 1974 and an ERISA exemption to allow it. We had broad coverage of the population. We had mandated comprehensive benefits, no deductibles, limited co-pays. With all of that, we had among the lowest health insurance premiums in the country. So we were doing well, and all of that has been undone. We've been losing doctors rapidly. Costs have doubled since then. Everything's been going the wrong direction. And
wow.
We're still, Healthcare for All Hawaii has been advocating for this. Democratic Party Health Committee has been advocating this. I've been active with both. We've been pushing the Hawaii public employee unions to consider this. We've been pushing Medicaid to consider this, and so far we have not gotten anywhere.
Thank you so much, Dr. Kemble. I'm going to turn it back to Marcia now.
Thank you, Gary, so much for that excellent management of the Q&A session. And thank you, Steve, for your excellent answers. I mean, every time I hear you speak, I learn a new wrinkle or detail that out of your vast storehouse of knowledge. So that is really helpful to me, and I hope it's been helpful to everyone else. Something that people mentioned was they wanted to know how to volunteer. So I would like to say that we will be posting up, oh, there it is. We have the volunteer link posted right now in chat. So please copy that off and click on that, and then you can enter your information and let us know exactly in detail, as much detail as you want, about what you would like to do to move our mission forward. Thank you so much for that excellent idea of bolstering our research and our outreach and our advocacy. Very much appreciated. So, and please do continue donating. And we had wonderful donations from Mary, Craig, Steve, Libby, Catherine, Lisa, David, Kimberly, Aruna, Florence, Chris, David, Ingrid, Jane, and Sherry. Now, if I forgot your name, I do apologize, but the donation window is still open, and as we convene the business meeting, so please do, the ticker is still rising, so we appreciate anything you want to, any support you want to give us at this time as well. We will, let's see, we do have the fundraising thermometer. Oh, we just had another $100, so it's $3,425. And we have somebody sharing that, graphic, I think. So please go ahead and share that graphic on the screen there, whoever has control of that. While I say welcome to our 2021 annual business meeting of Healthcare for All Washington. The agenda now should be, for this business meeting, should be up there on your screen if that can be shared now. Oh, first the thermometer. First things first. Thank you, Ronnie. And so yes, this is where you can watch your donations progress. Oh, wow. That's more than halfway to our $6,000 from attendees today. Thank you so much, everyone. So now let's have the agenda. Thank you, Ronnie. So our first item of business on the agenda is to approve the agenda. So this is it, as you see. Are there any additions, or do we have a motion to approve this agenda from the members now here?
I so move.
Thank you, Ronnie. Is there a second? David Loud seconded in chat. Okay. Thank you, David. Appreciate that. So now we'll move along. We've got the same agenda as we had. Approve the minutes from the November 15th, 2020 annual meeting 1 year ago. And we're sharing that on the screen now so you can see those minutes. In a moment, they will be shared. We have a scared cat, is what I can see right now. That's a really great cartoon. Okay, thank you, Ronnie. So Ronnie's scrolling through the minutes of the last meeting. You might have to move your little, if you have grids, panelists along your side of your screen, you can move those off to the side to read the whole slide.
I think that the attendees' view should be clearer than yours and mine.
Oh, good. Oh, good. I'm glad somebody has a clear view. So those are the minutes from last year. Are there any, is there a motion to approve these minutes? Chris Covert-Bowlds, thank you.
Second.
And who's seconding?
DW seconds.
DW. Thank you, DW. So all those in favor of approving the minutes, we've got a poll just appeared on your screen. Please answer yes, no, or abstain. And I would say that this vote is we usually restrict our voting. We always restrict our voting at annual meetings to contributing members only. So if you are a contributing member, and it's a very good chance that you are because of all the donations we received today, please go ahead and mark your ballots. And we have, great, the results are great. It looks pretty good here, 95% approved. So we'll go with that. And then the next item on the agenda here. Just a minute. We're going to see. Can we see that agenda again? Because I'm getting lost.
So it's the election of new members of the board.
Oh, okay. So then we need to have Connie added back in as a panelist so that she can actually speak. If you can do that while we get that going. Connie Rock just joined our board earlier this year, but the membership has not voted her in officially. So that's what this little bit of business is. So now it's time for the membership to weigh in. And first, we'd like to hear a little bit about Connie from herself. Can you tell us, say a few words, Connie?
Sure. So thank you, Marcia. And I first became involved with healthcare activism in 2016 when I joined the Healthcare for All Social Action Committee at Temple Beth Am in North Seattle. I've been with Healthcare for All Washington, this organization, as Marcia said, serving on the board since this spring, and I'm a member of the communications committee. So why am I passionate about healthcare? Although I'm not a healthcare professional, like so many of us, my life has been impacted by a healthcare system that just doesn't work. Several years ago, a close family member of mine experienced a health crisis. Emergency responders had to break down her door because she couldn't get up. She was in and out of the ER and the hospital 13 times over a matter of months. When insurance wouldn't cover a $30,000 a year life-saving drug that this family member couldn't afford, I was absolutely panicked. Nobody should ever go through this. Unfortunately, this story has a good ending. She was able to qualify for a financial assistance program for this life-saving drug that she so desperately needed and couldn't afford herself. Not everybody is so fortunate. I believe with all my heart that we can change our broken healthcare system. And we can do that through sustained advocacy leading to policy change. And this is exactly what Healthcare for All Washington is working for. This is why I'm proud to be on the board, and I hope to be able to continue to serve. Thank you.
Thank you, Connie. Get back up here. Very much. It's nice to hear that story. I hadn't heard that story before, so thanks for going public with it even. So I want to say now that we'll be putting up a poll to for the membership to weigh in on whether they approve of Connie to be on our board. And is that poll visible now?
Yes.
Oh, okay, great. Okay, so you have one choice: yes, no, or abstain. And this poll will be open for another minute or so, or 30 seconds, however long it takes to get your opinions recorded.
Looks like it's complete.
Yay. Okay, thank you. Okay, so now
sharing the results of 96% in favor and 4% abstaining. No one is against. Thanks.
Good. Congratulations, Connie. We appreciate your willingness to serve on our board of directors, and especially your expertise in communications on the communications committee.
Thank you. Excited to be here.
Yay. Well, it's been a great privilege for me to serve as your president. Over the past 5 years, we have strengthened our relationships with legislators, become more effective lobbyists, and increased our statewide outreach through our second Wednesday speaker series. During the past year, our membership grew by 12%. Also during the past year, your Vice President, Ronnie Shure, worked side by side with me in leading this organization. And that is why the board recommends him for your consideration as our next president. Ronnie, we'd like to hear you say a few words about yourself now.
I have been active in healthcare reform since I graduated from pharmacy school in 1970, and that's a long, long time. It's been so exciting to see things moving forward here, especially here in Washington State. So it's been great to be a part of that. It's been great to be working with Marcia these past few years, with Chuck Richards prior to that, with the allies in various in other advocacy groups around the state, and with this powerful board of directors. So I'm excited about standing on Marcia's shoulders. I hope it's not going to be too painful for you to take over as president.
Thank you, Ronnie. That's great. So at this time, I want to make sure I'm seeing the Al Bergstein's cat on my screen. Is everyone else seeing that too, or do we have?
The attendee screen that I'm watching over in the corner, you can see me turning my head, does not show the black cat. Oh,
okay. All right, excellent. So let's put up that poll then, Ronnie, for your election, for people to decide whether they're in favor, not in favor, or they don't want to say what they of you becoming the new president. And that'll be up for just a minute now.
So it looks complete. I'm going to share the results.
Wow, unanimous. This is great. thank you, everyone. And this is the best vote most unanimous vote we've had all session here. So that's really exciting. Now, as that makes me, that makes Ronnie the next president, and that makes me our immediate past president. So let me be the first, Ronnie, to welcome you to your new role as president of Healthcare for All Washington. So Ronnie,
So I guess we should have a virtual handing back and forth of a gavel or whatever it takes.
Right,
so
here you go, Ronnie. My hat's off to you.
And so I'm going to ask Chris Covert-Bowlds to move to our panel and open up your video. So the next office is for Vice President, and and the board is nominated Chris Covert-Bowlds. And so if you could start your video and share a few comments, which you actually started earlier today and leading that session.
Thanks very much. Yeah, as a family doctor, I'm very motivated to help get health coverage for everybody in the state. And if elected, I will serve.
Chris has already described his role and shared several stories with us. And so thanks for being willing to join our leadership. So now I'm going to launch the poll for Vice President of Healthcare for All Washington. You have your guitar out, Chris. You could play a little. No, you don't. So it looks like the results are in, and it's 100% in favor. So thanks, Chris.
Thank you.
Appreciate that. I'm trying to run the Zoom webinar at the same time. So now I'm going to ask Peter to move up to the panel and open up your video and ask you to unmute yourself. The board is nominating Peter Lucas as the new treasurer, following in Dana's footsteps and in my temporary sandals or short-term action as treasurer. So Peter, can you turn on your video, start your video, and unmute your audio, whatever the right term is?
Yeah, I'm having a little, this is acting a little buggy. I'm trying to get myself on video here. I'm having trouble. You might just have to hear me, but maybe, oh, there we go. Here we go.
There you go. I see okay. I see you now.
I'm Peter Lucas. I'm a practicing psychiatrist, and I have firsthand knowledge of how our dysfunctional healthcare system gives patients the shaft. So I've been involved with single payer work, both with Physicians for National Health Program and with this organization for many years. And I think this organization is well situated to carry the, make progress in this area and to actually implement or actually get past the single payer healthcare bill and do other things in the meantime. So I very much believe in this organization, and I'm pleased to be considered for treasurer and looking forward to learning some new software that's going to totally baffle me.
We'll try to keep it simple. So I'm launching the poll for treasurer of Healthcare for All Washington. So it looks like we've got a completed poll of 100%. So thank you, Peter.
Thank you.
And I'm going to close that and share. And so, Peter, you can go ahead and mute or stop your video. Is that the right word? Stop. And the next two items of business are just to ask you to ratify the strategic plan and budget that the board has approved. We've struggled with this, developed it at a very productive, well, actually, there's one more thing before we talk about the strategic plan and the budget, which is I would like to take a moment to ask Sydney to turn on her video. Sydney Jones is our communication specialist who maintains our website and who helps manage these communications that come out to you. And we have just expanded her role, and she's agreed to it, to take minutes and to perform many of the secretarial duties. So let us all say thank you. And I don't know if there's a reaction in everybody's little QA or just to send your good wishes her way as Sydney starts to take on an even broader role with us. So thank you very much, Sydney.
Thank you.
So now I would like to, so you can go ahead and stop your video, Sid. Thank you. And I would like to share the work that we did with the strategic plan. It started in a retreat with a great facilitator in the summer this year. We updated the strategic plan, adding in equitable care, but still continuing the basic principles that we've performed or promulgated for the past few years. I just made it disappear. This year's strategic plan includes the Universal Healthcare Commission and its movement and committees that are going to grow out of it, and the fact that we should all be paying attention to it, but also some important legislation that we are going to be supporting during the year. And I move to the strategies. Certainly the Universal Healthcare Commission committees are at the top of our list, but there are boards that have been developed by previous billing or by previous legislation that's been approved in the past year or 2 years, and work groups that are still being developed. The state healthcare authority and Department of Health have certainly been overwhelmed with COVID activities during the past year or so, but hopefully they'll be moving forward, and 2022 should show some improvements. Strategy C is looking at promising legislation from the past, as well as new legislation that our legislators are putting forward and are developing as we speak. Strategy D looks at action teams and expanding the work we've started years ago that seems to go up and down as we get new and volunteers, and as some volunteers age out. And strategy E talks about building that momentum with our coalition partners. We're so lucky to have healthcare as a human right leading or pulling a number of advocacy groups together to move towards publicly funded universal healthcare. Strategy F talks about fundraising opportunities that we are working on. Strategy G is about communications and moving forward some of our presence in social media and the speaker series that we started. And strategy H is to broaden and diversify our leadership team, some issues that we've been working on for several years. If you have questions, the strategic plan will be available on our website shortly, and we have approved it by the board, but we would like to get your sense of approval or support for that. So I'm going to launch a poll now to ask you whether you are in agreement with that strategic plan. So thanks for jumping in for that. And as you can see, we had 100% ratification of that. And so the next step is the yes. The next step, as I was saying, is to ratify the budget that your board has approved. We have set a fundraising goal of $40,000 for the C4 Healthcare for All organization, $15,000 or more for the education fund contribution to basic operations, as well as some goals that we will set through Give Big Day in May to improve our education activities. So a total of $55,000 fundraising or revenue estimate. The expenditures that we are planning for the year are $31,000 for staffing, which includes some bookkeeping expenses. We have assigned a contract or gotten a contract with our Northwest Financial Management organization to support us in doing accurate taxes and new things that show up, such as long-term care fund. Then we are asking for $2,440 in our operations, which includes licenses, streaming through Zoom, and miscellaneous printing. We actually are bulking this up this year with the thoughts that we will have some in-person activities. And so printing some updated materials are part of that expenditure. And then for standing committees, it includes political action committees, such as political action, such as our lobbyists and events that we are hoping to plan, Give Big registration, different training, and we actually are allocating some advertising money to create a better presence on social media. And then finally, events such as this annual meeting, which we are hoping to have in person in the future, as well as an annual retreat, which we have found very useful in organizing the board. And as you can see, just from the new board member and the new vice president and treasurer, that the board is moving forward. And so this is to support that activity. So total expenses of $50,290. And if you have some questions, please feel free to put that in the Q&A. And this is a budget that was approved by your board of directors, but we would really like to get a sense of your approval for it. So if there's no questions, I'm going to go ahead and launch a poll to ask for your support. So it looks like we had 100% support for that budget. Certainly let any of your board members know if you have questions about that. Those are the key points, the business that we wanted to take care of. You have done a great job at following and helping us make sure these things are happening. And so now I'd like to move a few people, like especially Marcia, back into the panel. So are you still on the panel? Oh, you're still on the panel. So Marcia, if you could turn on your video.
I need you to turn it on. The host has to. Yes, thank you for the invitation to.
And let's pull a few other people back in and show a few more friendly faces on the screen, and we'd like to start out with some brief acknowledgements. Oh, where is Sherry?
She might be an attendee.
She's here, and I just need to move her over. Sherry, why don't we start with you, if I could ask you to turn on your video and unmute your audio. So we have a few, well, let me start with this. I know I have asked you to open up Sherry. So before you open up, we have gotten our heads together and thought about your next steps, Marcia. And so we'd like to share a small gift that your board would like to share. If I can get the right buttons. Sorry about this. One of the things we certainly are looking for in volunteers is someone who knows how to do this Zoom webinars and meetings better than you. But I will send this to you in an email. We know that you're going to be moving on. You've shared with us that you've got a pile of books that you need to read, some work around your home and garden, as well as getting back into life. And I think we're all hoping that the pandemic will end. But I'll share this with you. So we'd all like to thank you for that. And let's start off with Sherry to share a few personal words. Sherry, do you want to begin for us?
Okay. Well, it's been a lot of years, Marcia. It's been just terrific. You've done a great job of pulling this organization together and keeping it from collapsing and even building some strength into it. May it continue. And I used to work in Woodinville. When I was in practice, my office was within walking distance of Molbach's. I think you will enjoy our gift there very much. I don't think the place has changed. At least I hope it's still recognizable there in Woodinville. So thank you so much for being there for all of us. And don't go away, because one of the positions for the immediate past president is to come join us on the Ed Fund board.
Thank you, Sherry.
There's just a huge amount of work involved.
Thank you so much, Sherry. I appreciate that. And I just wanted to share with everybody that the very first action team meeting that I ever attended was with Sherry at the helm of that meeting it was in Redmond at the library. Must have been like at least 10 years or so ago. And I was very impressed. And I started asking questions then, and I'm still asking questions. So appreciate that Sherry's still here too to answer them and to find out more sources of information. She's a wealth of knowledge. Thank you for your kind words. And Molebox is a little different. It's bigger and it's glitzier, and they've got all their Christmas stuff out now, including the Kringle.
So let me introduce or open up, ask Lynette and Denny, Lynette Veers and Denny Delwell from Eastern Washington to add a few comments.
Well, thank you very much. And Marcia, I just hope we see you many times during the next few years, because the past 7 years have been just wonderful. Your help for us in Eastern Washington, coming over here and taking our hands and bringing us over there, because we started in a book club where we found a book that really was interesting, invited the author, and we got hooked. And you brought us into the world, and you made it so much better for us. And thank you also, having been an ex-legislator, you also contribute a tremendous amount in your testimony before the legislature, because that is one of the most valuable things for getting a bill passed. You did it, and thank you so much.
Yeah, and my turn. Yeah, Marcia, I think you are one classy lady. You are organized, and you're also gorgeous. And you really have been the face of universal health care and healthcare for all in Washington. And I'm so glad you're out there in front. And thank you for the time and energy you've given us. So now you take care of you.
You go, girl.
Thank you. I will go. I promise, Ronnie, I will go.
And can we get Chuck to unmute his video? Chuck Richards was our previous president and leader.
I think I pushed the right button. Let me know if you can hear me.
Good.
Okay. Marcia, it's really a treat to be at this meeting and to help congratulate you on becoming the new past president. I can imagine a little bit of what it must feel like.
Oh, yeah.
I think there's two things I'd like to talk about. One is how much fun it's been when I was working with you, and also then to talk about all the energy you have put into healthcare for all. I still remember all the tabling we used to do and joking around in the rain and stuff at Edmonds and Shoreline, and I don't know how we got talked into Bothell. Can you remember? And those parades marching in Bothell in the summertime. We had a lot of good times. I remember also when we would go to Olympia or other places, then we always look for a place to have snacks or lunch or something afterwards. And you're always very enjoyable to be hanging out with. But I'd also like to talk about your energy. I've always been impressed. The 10, 11 years that I have known you or seen you work in the last couple of years. I think the image that I think anybody who's worked with you knows that being in any meeting with elected officials, it is so great to have you, to be in the meeting with you. You have got such a presence, and you are so skilled at listening and conversing with the elected. So I don't think they ever figured that you were lecturing them. You were always conversational, and I think that's a great gift. And then after the meetings, I think your strategic sense is really valuable. You've always been able to help get a conversation. What do we do next? And what's the best approach? And maybe last of all is anybody who's ever been in a hearing room in Olympia with you up front speaking on our behalf, know that your presence, and I think even from the camera angle when I watch videos, You're looking at the legislators and you're talking to them, and you're not like preaching again like some other people are wont to do. It has always been great working with you. And I think your energy has really situated healthcare for all in a very good position for what's coming next. So thank you so much for your 10, 11 years of dedicated work.
Thank you,
Speaking
Chuck.
of people at the front of the legislative room who's hearing Marcia's direct comments, Senator Cleveland, who's the chair of the Senate Health and Long-Term Care Committee, would like to share a few words.
Thank you, Ronnie, and hello, Marcia. Hello, everyone.
Hello.
It's so good to see everybody. And, as Marcia is handing over the baton, I am really grateful for this opportunity to join you today to share special recognition that Marcia so very much deserves. As a member of the legislature now for nearly a decade, and as chair of the Senate Healthcare Committee, I've had the just distinct pleasure of working with Marcia to further our shared goal of healthcare for all in the state of Washington. And for those of you, I know you all know Marcia, I don't have to tell you, she is a strong advocate. She is proactive, she is patient, she is soft-spoken, but she is tenacious, she's firm, she's strong, she's respectful, and she's always very positive. And it's really this unique combination of qualities that has made Marcia so successful on your behalf. And in Olympia, you all well understand that it's positive relationships built on trust, built on respect, that effectively get things done. And Marcia's attention to building those strong, enduring relationships, in my opinion, is exactly what has made Healthcare for All Washington really the leading voice on universal healthcare in this state. And, it's also, I think someone else alluded to it as well, it's also her strong understanding of the legislative process and of the fact that, policy making has to first begin with building a really strong foundation in order to then be successful in the future and continue to drive toward that final goal. And oftentimes I think about how building policy and strong policy to me seems a lot like building a house. You have to first lay a firm foundation that's going to then support a sound structure. But laying a foundation takes meticulous work, and sometimes it's frustrating, particularly because that foundation is not always visible from the street. But it's absolutely essential if the house that you're building is going to stand the test of time. So Marcia, what I want to convey today to you is that the foundation that you have laid is going to allow for the sound structure to be built for the future that's going to stand the test of time. And from the passage of legislation to create the Universal Healthcare Work Group to all of the long hours spent participating in that work and ultimately putting forward recommendations that included the establishment of a permanent Universal Healthcare Commission. And then, of course, all of the hard work that went into passage this year of legislation that creates that commission, that the foundation's now, very firmly in place to really start putting the walls up, so to speak, and building that strong house going forward. So, Marcia, thank you for all your hard work. Thank you for making it possible for now others to continue work on the structure. And I'll just say, as Marcia hands the reins over to Ronnie, I certainly am at the ready to continue working together in a collaborative way to ensure that we don't lose focus on that final goal that we see up ahead. So thank you for allowing me this opportunity to take a moment to really acknowledge and thank you, Marcia, for all that you've accomplished. You've been such an effective partner, such a tremendous advocate. I'm going to miss seeing you in Olympia regularly. If we ever get back to Olympia, I don't know if Olympia is even still there. I haven't been there for so long, but I'm going to assume that it is. And, I know that you're going to continue to be involved in the work ahead, and just thank you.
Thank you, Annette. Senator Cleveland, my friend Annette. I appreciate your words. Thank you so much. And I will be involved. Don't worry.
Yep.
Thank you.
And David Loud, from one of the co-chairs of the steering committee for our statewide alliance, would like to say a few words. David, I can't seem to move you, or you don't seem to be moving to the panelists, but you want to just talk?
Maybe he needs to turn on his camera, because I see a square with his name in it, but I don't see him.
Well, while David's doing that, several other people have asked to come in and say something, but I think we're running a little bit out of time. One of your legislators from 1st District, Derek Stanford, who has followed you from the House to the Senate, or has heard from you in both the House and the Senate, had wanted to make a few comments. But I don't seem to be finding him in the attendees right now, but he would certainly,
Yes, David Loud here. I'm sorry, I'm flubbing getting the picture on, and I was also looking for the comments that my steering committee co-chair, Nathan, had sent. He's out of town right now. He had sent some remarks to thank Marcia, so I'll just speak for both of us and say, Marcia, we've been working together for quite a while, and it's been very good. And I want to second the things that people have said about you. I'll be very brief, but just to say, I don't want you to go away. You deserve a break. You deserve a break. You deserve to do all the things that Ronnie said you were going to do, but we need you in the fight. And so I count on you to be around, but it's been very, very good to work with you. And I think we really have advanced the movement for health justice and universal health care during the time you've been at the helm with Healthcare for All. And now we're on to the next phase, and I think we're going to do well. So thank you for everything. And that's for me and Nathan.
So thanks, you, David. And going from the statewide coalition, I'd like to welcome Chuck from the One Payer States, a national coalition of states that Marcia has had a major impact on. Chuck?
Thanks so much, Ronnie. Yeah, this is a great honor. I'm sorry to be running behind a few minutes here, but Marcia, you have just been a real treasure at One Payer States, and obviously in the state of Washington. Always a delight to work with, always accessible, always rational. Not everybody is at all times. We've done a lot of great brainstorming together. I think we've developed some good best practices, you know, in terms of communicating among and between states, because Washington State is a leader, and so much of that is attributable to the work that you've done, Marcia. And you know, Ronnie's got some pretty big shoes to fill here. So I'm just so excited for what's happening in Washington State, what's happening in the Northwest with our other partners. In other state efforts across the country. It's a very exciting time, I think we are right now. And we just have to keep at it and stay vigilant and just stay focused. We don't know what's around the next corner, but Washington State is an absolute leader. And thank you so much, Marcia, for all you've done. I treasure you as a friend, as an organizer friend, as somebody who has inspired me to do better work over at One Payer States. So on behalf of One Payer States, which has been around now for 12 years, a group unlike any other in the country, you've contributed so much. So thank you so much, Marcia, for all you've done.
Thank you, Chuck.
Thank you. Ronnie,
Marcia, do you want to close us out with a few tear-filled, oh, no, you can't cry. You're not allowed to do that. you'll have to wait for another board meeting or something to do that. But do you have some final comments to share?
Are you asking me, Ronnie?
Yes, Marcia.
Oh, yes, I do. I'm glad I get a chance to reply to all that's been said so far, because I could not have done any of this without each of you being here in my life, in the movement with me. So thank you so much for joining me and all of our other advocates here in this work. It's not a one-man show, and no one of us can do this work all by ourselves. We need to collaborate. And it's been a pleasure to collaborate with each one of you as we've gone through these years. And I look forward to more collaboration in the future. I know that I will not be able to leave this issue behind. It's like printed in my DNA somehow. So thank you for making this fun, and I hope we have more fun in the future.
And so thank you. I think board members will certainly say more in our next upcoming meetings, and thank you for agreeing to be immediate past president. And just, I noticed in reading over the bylaws that there's nothing that says you can't become an officer again in the future. If you find yourself spending too much time riding your bicycle or taking care of your lawn or your family. I don't know if you wanted to share your family news you gave me yesterday.
Sure. So I was notified yesterday by my daughter that I will be becoming a grandmother in June. So I'll be taking a trip to see the new grandbaby and the family down there. Thank you.
Well, thank you all very much. It's been a great presentation, and thank you all for coming in and joining us even at the end to help welcome welcome Marcia to the new phase, the transition to immediate past president. So thank you all. Have a good night.
Thank you, Ronnie. Good night, everyone.